Hello. The topic for discussion is normal pressure hydrocephalus, a condition sometimes underrated in nephrology. Many CKD uremic patients are presenting with this condition, especially in encephalopathy. Before directly discussing the what is the importance of this one in CKD patient, first we will see what is this normal pressure hydrocephalus. That is the topic for discussion today. If we take the CSF circulation, it is produced in the lateral ventricle from the choroid plexus, forms the buffer in the brain. It goes through the circulation, third, fourth, and subsequently absorb into the arachnoid villi into the bloodstream. Suppose if there is any obstruction to this flow, that is called as obstructive hydrocephalus. That is called as obstructive hydrocephalus. Suppose if there is no obstruction to the flow, but the ventricles are getting dilated, then it can be called as non-obstructive hydrocephalus. When there is no obstruction, we will call it as non-obstructive hydrocephalus. In simple terms, it is communicating between where lateral ventricle, fourth ventricle, third ventricle, and to that external buffer where it gets eventually absorbed into the arachnoid villi, that area. That is why hydrocephalus grossly of either obstructive type or non-obstructive type. Non-obstructive type can also called as communicating hydrocephalus. Normal pressure hydrocephalus is a type of non-obstructive hydrocephalus and it is communicating one. Since the ventricles are dilated, the CSF pressure is not raised. That is why the terminology is the normal pressure, the opening pressure in the CSF or the signs of intracranial pressure might not be there. That is why the terminology is. So what is this normal pressure hydrocephalus? It is a type of communicating hydrocephalus. There is no obstruction. So it is a condition where pathologically ventricles are enlarged with a normal opening pressure on lumbar puncture, hydrocephalus. That is why it is being some text you might find it is a form of communicating or it is a form of non-obstructive hydrocephalus. The CSF volume increased, ventricles dilated, brain is basically being compressed, the ventricles are dilated. What are the situation can cause it? The etiology can be primary or secondary. Primary means basically there is no clear-cut cause, more common in the old age group. Secondary because of the chronic inflammation like meningitis, old age, diabetes, hypertension, CVA, arachnoiditis, any inflammation. And many places we might not find this particular terminology, uremia. Uremia is also one of the cause. A resident or a person who is watching this video, if you are in the nephrology department, over a period of 3 months, at least you might have find 2 cases of NPH, normal pressure hydrocephalus. It can be primary is idiopathic. No particular etiology is found when the patient is developing. Here in the secondary, there are etiologies like chronic inflammation, diabetes, hypertension related stuff, cerebrovascular accident, uremia, and the calcification. Some kind of bone disease, for example, Paget disease, some deposition disorder. These are MCQ related. Deposition disorder can also cause this. Overall, practically or the clinical purpose, which thing you have to remember is meningitis, uremia, and CVA. Uremia in CKD is very common. Probably in the upcoming literature, it will be added up. What are the clinical features? During your UG or undergrad, you might have studied this. There is a triad where there is a dementia, gait abnormality, and urinary incontinence. This is for the MCQ purpose. Clinically, if it is presenting in a patient, gradually it will present. Patient might be having cognitive disorder. his emotional viability might be there, frequent forgetfulness, gait, magnetic gait. The gait goes bit abnormal. Urinary urgency might be the initial one to start with. As the day progresses or as the month progresses, the patient might land in incontinence. This is the classical triad, but many a times this classical triad might not be there. A patient might only present with cognitive issues, only present with cognitive issues. With respect to CKD, what is the particular thing? It is one of the differential for uremic encephalopathy in a patient who is not responding to dialysis or worsened after dialysis. Definitely, you might have got the CT done, but make sure you are looking for this kind of ventriculomegaly. Ventriculomegaly in CKD patient, it might have an abrupt onset. All three can be together. Patient might be totally altered, and encephalopathy is also common. Cognitive issue, magnetic gait, urgency. In a non-CKD patient, it is usually these kind of slow strut, and this forms one of the differential for Alzheimer or diseases which is associated with the dementia. But considering the nephrology, the patient can present in an abrupt situation with encephalopathy. That you have to remember. So, what is the clinical picture? Another clinical feature to note is the signs of increased ICT might not be there. The signs of increased intracranial tension like severe headache, papilledema might not be there. Okay. So how to diagnose? Imaging, basically the history. We will go step by step. As the clinical examination, before that history, the clinical examination, many things to rule out a CVA, those kind of stuff. I hope you might be knowing. With respect to the CNS examination and all, once it is completed, once we come to the particular diagnosis, it is always the MRI which is preferred than the CT. At the baseline in the emergency, it will be very difficult to get the MRI done if the center is busy. Always we go with CT, which is the initial investigation of choice, where you will be seeing ventriculomegaly. What is ventriculomegaly? Is nothing but the dilatation of the ventricle. The ventricles will be very big. Even a second year or the first year resident might find something is abnormal. It is not related to a normal CT scan. Like that, you can pick it up. MRI will easily catch, and there will be periventricular white matter lesions might be there. But most important one is the these kind of ventriculomegalies. The ventricles is very much dilated like this compared to the normal. The ventricles is very much dilated. So what is the treatment? Particular treatment, apart from the investigation, we have to get the basic blood investigation done and all. If we come to the particular treatment, it is the CSF drain. The pressure might be normal up to 30 to 40 ml of CSF drain, and the response to the CSF drain can be checked. VP shunt, ventriculoperitoneal shunt. Since the ventricles are dilated, CSF is accumulating, we have to divert the CSF to the other area, that is commonly the VP shunt, ventriculoperitoneal shunt. A shunt will be placed from the ventricle to the peritoneum. There are criteria to decide which patient requires. In CKD patient, usually adequate dialysis, supportive care, CSF drain will be more helpful rather than the VP shunt because it carries its own side effect. In a non-CKD patient, SVP shunt is one of the important treatment modalities that can be decided based on the patient response to the CSF drain. Before that, we have to come to the likely etiology of the condition, why the patient might have landed it, whether it is CVA or diabetes or chronic meningitis. If it is meningitis and all, it have to be treated, meningitis etiology to be done, CSF analysis have to be done, accordingly the treatment have to be. The two treatment discussion we discussed here is only particular CSF drain and the VP shunt. And other encephalopathy related supportive care like bowel care, bladder care, the patient nutrition have to be taken care of. With respect to a CKD patient, a low clearance, so that patient should not land in superadded DDS also, that have to be taken care of. And this is a CT to show the VP shunt. From the ventricle there will be artificial shunt. through the skull, it will be taken to the peritoneum. And what are the complications? The patient sensorium eventually might be altered. The chances of recovery is less if it is treated at the later point of time. Treatment related to the complication like VP shunt infection and all can happen. With related to this condition, in a non-CKD patient, chronicity, more the chronicity, less the chance of recovery. Dementia, it might come confused with the other DDs. These are all the few of the complication. Whereas in a CKD patient, yes, of course, sensorium is an important one. Patient might be in chronic encephalopathy, and if it is properly CSF is drained, patient recovery will be faster. VP shunt related infection and the patient's BP fluctuation, heart rate fluctuation, these kind of things can happen during the acute episode. So this is all regarding normal pressure hydrocephalus, and this in the nephrology prospect CKD patient, end stage patient is very common. Bye bye. We will see in the another video.